Good afternoon. Can you hear me? Yeah, I guess I can hear myself. Thank you so much, Greg, for the kind introduction. Thank you to the organizing committee for such a wonderful conference and putting it together at this time. It's great to be back, and congratulations to the new board. I think it's a great step, and it's a big shoe to fill after Greg, I guess. But we're here to help. Wish you all the best, and I definitely see WADEM growing to a next level throughout. As Greg mentioned, I will highlight that I did graduate back in 2000, but I have to confess that since I graduated, despite 8 years in medical school and internship here in Ireland, I did not visit Killarney, and I'm regretting every single day that why I didn't do that. But I think thinking back as a medical student, honestly, with the on-call and being an intern, I think I would know why now I didn't. So it's been a while seeing the airport. It's all flashbacks, but it's always wonderful to be back to this wonderful country. I think everybody who I spoke to felt the warmth that I felt for 8 years. Ireland is an amazing country. Irish are amazing people. So honestly, I always say, even when I work, I have Irish people working with me in Abu Dhabi, and I always tell them I have an Irish blood. So I'm honored to be a graduate of Ireland. So thank you so much again for the invitation. So I come from the United Arab Emirates. Abu Dhabi and Dubai, I'm sure you heard about it. It's more of a central hub now for tourism. This puts us at a responsibility at the government now of being prepared and really investing on a lot of the emergency management aspect of things. There's luckily mandatory health insurance system as well now. Ethnicity is over 200 nationalities in the country. So being sort of culturally sensitive and also politically correct for different accommodating country, this is something we really aspire to be. The healthcare is definitely at the forefront now of the government. They're really willing to invest, and they want. I see them, I sit with them, they want. But here where we come now into how to really take this into reality and being able to invest. We're over nearly now 10 million in population, and also a very big investment into the business side. I'm sure if you didn't visit the UAE, you missed a lot. There's a huge tourism, lots of activities, the Louvre, the couple of nice tourist attraction. I would like to invite you to visit the UAE at some stage. The tallest building, top right there, tallest building in the world, and also a couple of destinations. This is the Future Museum. It's actually, I visited with my kids about 4 weeks ago. Beautiful, nice, futuristic look of how the world will look like in many years. So what I would try to cover in the next, I would say, 28 minutes or less, hopefully, is just an overview of the healthcare in the UAE and give an example of how that challenge could be translated into an opportunity. They give an overview of the Department of Health, talk about the emergency management within the healthcare, and that's a language that I think this is where we are here today, but translating it into the government, sitting with politicians and trying to advocate for what we do is always a challenge, and we need to be able to speak that language. It's not easy. Briefly talk about the benefits of the government-academia collaboration, and I'll give an example of that, and speak about the key areas for collaboration from my end as a government, but also what could we do and how can we replicate it in multiple places as well, and then talk about the future projects. So looking at it, the United Arab Emirates is 7 emirates. The big yellow is Abu Dhabi, where I work, and that's where the Department of Health is the local health authority, and that's where I'm positioned currently. I lead the emergency preparedness and response within the Emirate of Abu Dhabi. If you see, it's over 86%, 87% of the UAE land. The capital is there, oil is there, so it's a high-risk emirate, politically important as well. Dubai is the next top, brown, and also they have their own health authority. And we have 5 smaller emirates at the top run by the Ministry of Health. But Ministry of Health oversee the federal level as well. From an emergency management point of view, as a local government, we report to the Ministry of Health, the federal level, but also when it comes to health issues. But we also work with the Abu Dhabi Crisis, Emergency and Crisis, we call it ADCMC. That's the local emergency management agency where we all report to the NCEMA, which is the federal equivalent to the FEMA in the US. That's the national agency. This is an org chart of the Department of Health. The chairman is an equivalent of a minister level in the government of Abu Dhabi. That's more of the Ministry of Health, Minister of Health. And the black box also, the second one is the undersecretary, legal, HR, and so on. But our sector is there as one of the key sectors, and I do see a big support to it. And also moving, the one next to it, if you notice, the research and innovation and international patient care. There's an appetite for innovation. This will take me to the discussion on how collaboration with academia is important. We moved through the years. So back in 2008, it was honestly, I remember, it was a small room with a desk, 2 people. When I was actually about to finish my fellowship, when we used to do the HVA project. So I went, visited them. The guys are trying, but still there was no mature framework of how the government should look at emergency management in the healthcare. And that was challenging because, again, that's the entity is expected to plan the whole healthcare sector. So getting the right people in there was important. Couple of hits, that was mainly reactive. After a big accident, what do you need? And then you grow. And now we're spinning off to now at the current sector, but there's actually a tender ending tomorrow of reforming the sector into a bigger, sector and bigger center, trying to accommodate all the aspects that I'll try to highlight shortly. Luckily, we've been with all the support. We've been getting a couple of recent awards in terms of COVID response. Abu Dhabi was considered one of the, I think, got a couple of awards internationally as a sort of COVID response at a city level. Honestly, it was a great inter-agency collaboration. We've got a Stevie's Award and also Oster Award in the different aspect. One, I have to admit, the Web EOC project was out again of collaboration. I remember we had a mass casualty back in 2015, and I called Greg, and we discussed, and Meg Femino, an emergency manager at the BI, invited her to look at our hospital back then, and she said, you do need a system. And of course, Web EOC was well implemented in Boston and elsewhere in the US. We got it, enhanced it, and it really worked very well during COVID. And of course, data was power. So this was a good investment of those collaboration. You need help. No one in the government knows everything. But of course, we were affected by climate change. We're affected by COVID, many other things. But honestly, the challenge I see in our specialty that now stepping in the government is, where are we heading? When it goes to the government, what is the vision for what we want to do? There are different schools, different projects here and there, but you need to be able to tell the government, the ministers, the undersecretary, because honestly, the moment I leave my meetings, finance people come in, workforce come in, and so on. So they're really pulled between different angles. Unless you refocus them with a very clear and simplified approach, you will lose the game, and then we'll continue, as Lori Mazurek mentioned earlier, 20 years from now, we will just keep saying the same thing, that we're complaining about what the healthcare is struggling from. No, it's a call for action from ourselves. We need to speak their language rather than, the other way around. We have to think of disaster medicine as an interdisciplinary, specialty. We cannot respond. Emergency management is not a healthcare only. We have to know how to deal with other disciplines, police, fire, other sectors, economy, and so on. So that language is important. So all the agencies that I've showed you, the same thing. So trying to push the healthcare agenda in is not easy. So we need to be able to get into that. What is the standardized training? I think we mentioned it over the last 2 days. Excuse me. What is the standardized training that we can do? So maybe WADEM or other entities can recommend high-level training that we can standardize across. Research challenges, resources, of course, is always a problem in disaster medicine. What are the priorities? Where do we start? If we have the vision, where do we start? That's also a challenge. So getting all of those challenges together in disaster medicine is important to understand, and how can we resolve it? What can we offer at the government? I think I'll need some water. So thank you so much. Appreciate it. Just one. I'm military, I drink from that. Thank you. So getting what the government can offer is important. So I think we were discussing it during lunch. I think understanding that the government has the authority, but we need the right opinion. We need to be able to get it at the right time by the right people. It's not, honestly, I've seen horrible decisions be made just because it's, made by the wrong people. So we need to use that power and stating what we voice. That's the way I would like to advocate for. Resources, we can get the military on. We can get, the different agencies allocating it. Many countries, agree that the government is able to allocate it, but is it the right way of approaching and utilizing those resources? Getting the message, I think Ronan mentioned this morning, that getting the right message, having those daily presses, there's an authority and credibility of the government. Whatever the government says is usually, the perception should be right. But that's where I think we can use this. We sometimes use the authority, not sometimes, all the time, uses the authority as well to align entities. I've seen so many heated meetings where people have the same mission, but they disagree on the way to reach that objective. So aligning those, using the authority, many examples I remember, just because we call them into one room and tell them that the government is there to support, now they're really well aligned and they save lives. So we have, ECMO programs, STEMI programs, and so on a day-to-day emergencies, just because we aligned it. I'm into, when I got into the government, I, start getting into this ecosystem and, how to work together. And this is the healthcare ecosystem with the different components. And I was always thinking about the ecosystem, right? So it's, thinking about it, how the universe works, and is there room for, what is our ecosystem, emergency care ecosystem? What are the components? So for those who know me, I cannot just, not present this slide. This is what I do day and night is, I have this vision that I'm executing now in Abu Dhabi. We managed, I'll update you on it. We actually managed to get, just because it's simplified approach, at least for my community, this is a Master of Public Health thesis back in 2010, finished it in 2011. And over 10 years or so, I was always speaking about it to the government. Went my own, I wasn't in a government position, but then I realized that I wasn't presenting it right. This wasn't the version that I presented. And I was complicating them when I speak to them. I got into passion and technicality. What the government needs to know is 5 things, and those are the 5 things. One is they need to understand that there's one lead agency for emergency care in the healthcare. So they need to agree on what is the one-stop shop that they need to agree on. So governance. And we managed to get the center as now we deal with ED issues. We deal with hospital preparedness. We deal with stockpile. We deal with the different entities. So now anything to do with emergency in healthcare, they come back to us, and we filter it. So for example, tomorrow I have an important meeting for emergency system financing. So it's not my domain, but we have to push it to be able to pay for the emergency care and so on. A second thing, I divided the emergency care within 3 concepts. One is the pre-hospital, which a lot of people think of it as an ambulance service or EMS service. It's actually way beyond. So what happens for mass fatality? What happens for volunteers that the guys spoke about yesterday, whether having a Good Sam app or others? All of these things. Where is the SOS system? How to define where's the emergency if we get it here? How to locate the problem. So a lot of IT, a lot of legality, a lot of components. So I try to simplify it on one domain because that's a whole concept by itself. The second domain is the hospitals. And the hospitals, again, a lot of people think of emergency department issues or hospital preparedness issues. We said, you know what, we're going to take care of everything that to do with emergency care, and we'll try to align it. And that's what WHO is doing now, the emergency and critical care and OT as well, they put it together. And we're thinking of the hospital as a whole, and this is something we're collaborating, I'll highlight it on you. The third piece, which we always neglect, and it was a wake-up call during COVID, the stockpiling. Who thinks about it? Blood banks, nationally and locally. Labs, I think, connecting it during COVID, monkeypox came up, another disease going to come up. Where are those labs? How can I connect them all together? That's a project by itself. Having, biosafety labs, level 3, level 4, that's a technical that we need to, we don't run it, but at least we make sure that it is there, somebody's thinking about it. Specialized program, STEMI program, it's not a disaster management, it's more of a emergency care as a whole. Poison center, believe it or not, we don't have a poison center. We just started it after lots of pushes into this, and now we have at least a drug information center, and we're heading toward the poison center. Mortuaries, mental health, all of those components that we need to think about it. But then, after thinking of the 3 domains, you need a hub, you need a brain to talk about data, data integration, system integration. We were looking for, again, registries. You need a brain to press a button and tells you how many emergencies in Killarney today, how many, what is the waiting time, what is that? So a lot of proactive, data AI plays a huge role. EMS dispatch and destination cannot, or I see it, I think down the line is done by AI, trying to reallocate where those ambulances should go. So a lot of technology can be done if we integrate the system. So governance, think of 3 components, and then link it into one-stop shop where all of those components are linked, how to deploy and how to integrate it, because to me, it's really very well connected. When I speak to the politicians, I tell them, look, I'm not stepping on anybody's toe. This is more of a health issue, but we're going to work with police, we're going to work with municipality, we're going to work with the media, but the framework is only a healthcare. We work with the emergency management, as I mentioned, and then that goes to the federal. Because the moment you tell them it's a framework, they think it's going to dominate their zones. It's actually not. I always tell them we're this little framework that we're trying to clean the homework or our little house. This is a nice book that I actually attended a workshop about a week ago, and it is from a group who used to work with Boston Consulting, BCG, and they highlighted the value-based sort of issues within the healthcare. And they listed unlocks, six unlocks. And looking at them, it's exactly what we struggle with in healthcare, in emergency care. So having a defined outcome measures and transparency within healthcare, This is really important. I think we need to define what we want to look at. The second component is having a patient-centric care delivery. I hope we are improving now, but we need to think of that patient as a journey, as a center of all what we try to do, rather than we assume that we're solving problems, and then the patient is our last. So this is an important item that I think we need to think of our own emergency patient centric. Incentives for value, what are the outcomes? Rather than volume, seeing patients, it's more of a value of what we're trying to add. Of course, data integration, technology, digital tools. As I mentioned, the world is years, decades ahead. So we need to catch up with that, how to use those technologies and benefit from it. Regulation and governance, I mentioned it also as well. We need to be able to govern. Honestly, being a clinician, I've led the emergency department for many years. I always assumed that somebody up there thinking about us. Actually, there were none. So unless we think or do it at the government, and hopefully many of you can step up to that level, we will make a difference, honestly. People listen, but we need to send the right message, being able to work together, and of course, having the right leadership buy-in to be able to support. So I cannot do this by my own. So this is where I think I went back to my roots. This is Greg, I would say, 15 years ago, and that's me 15 years ago. I really, tapped into Greg. Hey, I took over, and we've been working together. And thinking about what the academia can offer is actually a range of expertise, addressing complex challenges, from an evidence-based approach, different, capabilities. They have that capability where we think of a day-to-day at the government and very much of competing priorities. So that's a great tool or an advantage. Universities, engineering schools, social science, research centers, all of those are capabilities that we can work with. And again, of course, innovation and reaching the right solution, hopefully, and what we've discussed again over the past 2 days. How can we think of disaster medicine 10 years from now? That cannot be. I'm telling you, the government will not think about this. You guys need to consider it, and this is where the collaboration would be. So it is more of a patient care, but also it comes from academia and government. From a government, the authority, the resources, data. We're data rich. I can't tell you how much data we have, but would I sit for an hour, just dissect it? I can't. So unless we have the right collaboration and really, the right team, and of course we look at data, but not the way that the academicians would look at it. And this is where the collaboration comes in. So expertise on the other arm, evidence-based approach, research and innovation. That's, I think, a great merit between both. Of course, facilitating innovation, sharing knowledge, pooling the resources from, expertise and also synergy in capacity building, developing this coherent service, and finally improving the efficiency. And this is where we really want to be better every day. So we've been lucky to have this collaboration with the Harvard Medical Faculty Physician. We've signed an MOU back last year, I think. There's a short video of the signing. So we decided to go and select a couple of projects. So this is more of how this collaboration can serve hopefully the vision, and how can we work on it. So what we are trying to do now is, putting policies and standards together, working on the EOC concepts. We're training people as well, and we're working at the hospital level as well. This is a couple of the areas that we started working on CBRNE project. So the team came and and did a great assessment on the more of the radiological side, but of course looking at the capabilities, and it's always great to see what, the different opinions and what's out there. And that's also engaging the providers that we have on the ground. So when somebody comes from, outside and look, what can we do differently, it's always encouraging. We did a nice course, which I think, also helps tremendously. We started with 35 people, 2 dropped off, and we graduated 35 with a very nice, more sort of healthcare facility management. This is a quick video. So this was a 6-month program, and it's exciting to see, now we have 33 ambassadors within hospitals. That language was really important. It did not exist before. So having a unified, actually we put 35 competitors in the same room. And I told them, you know what, we're not here to compete. Emergency patients are not for competition. We need to work together. I said, go compete on oncology, dermatology, something else, but not in emergency care. So we need to work together because we will need each other during the emergency. This is another project we're doing now, is just standardizing emergency departments, outcome measures, systems as well. And again, those are competitors, but we're trying to set up a system. So the BI is helping us with it. We're working very collaboratively with the team as well to build our own EMT in the UAE. We have currently, this is the military field, but we're building a civilian EMT team as well. Where are we heading? I think, we do need training. We need to continue the education part. Certifying, we're building an emergency management academy, hopefully down the line. So building our own courses, this will be an important, either counterterrorism or others, things that you cannot just Google and find. There are certain gaps in the system, in the healthcare, that we need to fill. And people really need to this. And that's what I feel, honestly, a lot of people do ACLSs and PALs and the basic courses, but when it comes to reality, they cannot perform. So there are important I would say, bridges that we need to build in the system. Research, of course, I can't speak enough about it. That's an important component. Training together, supervising, similar to the drill that you've seen. We need to train and drill and exercise together. Of course, innovation, really, WADEM, please, let's work together and take disaster medicine to the next level. I think there's so much past that we are living now. We need to live the future and live it today rather than wait for others to I think, pass. In summary, I think the world faces complex challenges that requires innovative and effective solutions. We need to collaborate together. So collaboration between the government and academia has a potential to generate a significant positive impact on disaster medicine. This is from personal experience. Partnership really includes the access to expertise, resources, enhance the policy development, and advancing the specialty in disaster medicine. Challenges, of course, are there, but we can overcome it by building the confidence and the trust. The government, honestly, is fed up of consultants. They don't want to hear that word, but academia is different. Academia is very trustworthy, non-for-profit sort of approach, and evidence-based. So there's that mutual relationship that builds this communication. And of course, navigating toward ethical and legal consideration and propose solutions to the community. And finally, fostering collaboration and innovation can achieve our shared goal. So this is the paper. If you want to just look at it, it's a simplified, hopefully, thought. But I'll be happy to answer any question, I think, in the panel. Thank you so much for your attention, and looking forward to discussing it more. Thank you.
Thank you, Saleh. If you could maybe join us here for some questions. So if anybody would like to ask any questions, please come approach the mic. And if not, okay, please.
Thanks for this. I hate being the first one to ask questions, but I'm going to do it. My name is Faraz Khalid, and I'm at the Canadian Red Cross in Canada. My question is specifically about the framework you shared. And you mentioned during the presentation that one of the challenges that you were facing was getting everybody on the same page and telling them that, this is within our own house. It doesn't infringe on yours. So I'm just curious from your end, with your experience on this framework, what would you tell a country like Canada, if we're trying to build a similar framework, what are 3 things we should watch out for, and how do we actually address them to make sure that we don't fall the same challenges? Thank you.
Thank you. So one is, I think one you need to have, which it's already existing in Canada, which we didn't have, was the common language. So having one it's a both top-down approach. So one, I would say, make sure that this idea, or it doesn't have to be this exactly, but at least centralized approach within the healthcare is sold to the government. They need to see why. They honestly prefer to have one entity rather than speaking to 10 people. So this made sense to them, sitting to them and tell them, okay, but actually it has responsibility as well. So accountability and responsibility. So you need to be ready for any questioning. The good, and they will not come to you for the good, actually. They will come to you for the bad. So one, you need to make sure that a common language is there. The second thing is, dissecting it into smaller pieces. You don't have, we're only implementing it in Abu Dhabi now. Started small, now it's getting more. Dubai, we've met with them, they like the idea, and we're working with them on this. I see this hopefully, and I don't know, I will not be there. I always tell them I'm seeding, trees, and I don't want to see the trees. So but I know now it's there. It's well watered, it's there, it's divided. We have fund for it. We have, as I mentioned, multi-million grants to make this happen. So the government is there just because we simplified it. They spend millions on stockpile, millions on blood banks, billions on this, but they don't speak. Now we told them, okay, let's put it in one framework, and one entity will manage pre-hospital, entity will manage hospitals, and standardized training and so on. So a little bit of simplicity on the approach, and breaking it down. The third is, getting, again, if it does make sense, validating what you're saying. Because again, one person saying it is different than if many people agree that our challenge is complexity. So I actually, BCG, on the workshop last week, I've told them, is there anybody thinking about value-based emergency care? They said nobody. They lead this value-based as a consulting firm. They said there are militaries thinking of trauma, other entities, CDCs thinking of, outbreaks and communicable diseases, but nobody's thinking of this ecosystem again. So we need to be more proactive on how we approach it, but validate it. So make sure that what you're saying makes sense to your community, and this is just an approach that's working for us, as I mentioned. But you need to customize. Even in the paper, you'll say operationalizing it is local. This is a simplified approach of what are the 5 components. But I'm sure the politics in India will be different than Canada, than the UAE. So you need to take, hopefully, this simplicity and see how can I bring people together and move on with it.
Thank you. Please.
Hi, I'm Michelle Davison. I'm from Sunshine Coast in Australia. I was interested in the streamlining emergency departments. Are you talking about like lean thinking for your emergency departments? Okay. How are you achieving that? Because we're a small country, well, we're a big country, but we're a small from the population. But trying to get different hospitals to comply with streamlining care is pretty challenging for us.
Yeah, and that's absolutely. It's always. I'm not expecting a rosy, path, but at least having that governance. Because honestly, looking at hospitals, they look at their C-suite, but where the C-suites are getting the information is something that I think the government needs to speak up with. So when I meet with CMOs and CEOs of hospitals, we tell them, look, just look at the hospital and look at it as a holistic. Again, what Mick mentioned earlier, the problems in the EDs. We're emergency physicians. We just keep, struggling out of the problem of overcrowding and so on. But it's a system problem, not we're just a one part of it. But now standardizing it is important. We have a committee. We created a task force across different entities, chairs of departments, getting a buy-in from the from the C-suite and those facilities. They're all supportive, and we're creating this homogeneous, hopefully, culture within the emergency departments. And also, again, it's part of the collaboration. Professor Rich Wolf from the BI hospital, renowned person with his team, and trying to get what best practices in emergency department operations and introducing it to our own community. We have 12 emergency departments, not a big community, but we have many urgent care centers as well, so about 37 or so. So we're trying to align it, making the understanding that, look, we're here to help, rather than hammering you with punishments. So let's work together. It's all patient-centric, and we're getting good buy-in.
Please.
Thank you. Dr. Faris, I'm a GP. I'm also founder of disaster medicine and dentistry, worked on the front lines in Lebanon and various other countries. My question for you is the underutilization of GPs in disaster zones, as well as in the UK, the COVID response. In Ireland, I'm sure we've witnessed the same. Do you have any thoughts? I know you're primarily focusing on emergency medicine, but do you have any thoughts about the inclusion, involvement, and utilization of GPs in your framework or going forward in other frameworks? I just wanted to invite your thoughts on that, please.
Absolutely. So two aspects. We're utilizing the workforce overall, not just the GPs, but we're aligning with the sector. So we have around 60,000 healthcare providers in the Emirate of Abu Dhabi. Those are, again, from nurses, doctors, and different specialties. One is we're trying to align a minimum level of emergency management knowledge. within this, because this is what happened. I've seen it in mass casualties and others. You know, for example, I don't know if there's internists here in the room. I'm not into this. They just literally tell you. But we need a basic, you know, at least taking care of those green cases. I don't know who was it in Sudan. There was a news the other day, just ophthalmologist was taking care of patient, you know, in Sudan just, you know, lately. So what I mean is in crises or in emergencies or in disaster, we will need help. There was an explosion next to the last year. It was next again to a clinic. Patients were dragged into those clinics to stop the bleed and so on. So this minimum knowledge is important. Second thing is how to utilize them. So the team mentioned yesterday about the Good Sam app, and that's something we're implementing. So we're launching the workforce Good Sam. So we will not launch it to the community. So we're actually introducing sort of mandatory 2 hours course online to give them basics of volunteering, basics of emergency management, basics first aid skills. And we will you know, download the Good Sam app, and hopefully that will be part of this integrated model of we can deploy. So if there's an emergency here, we can deploy, you know, volunteers, and first phase will be the healthcare providers in that you know, sort of domain. And then, you know, we'll roll it out to the community, and hopefully slowly we become emergency management ready sort of community. The third is, of course, you know, the GPs themselves, being able to proactive, stepping up. So I don't know if you refer more to the family medicine side of things. We work collaboratively with them because part of the primary healthcare issues is affecting emergency departments. So it's our benefit to help and mutually work together. So there's a huge investment from the government on primary healthcare as well.
I think if I might add to that just a little bit too, exactly what Saleh says, but you know, I think whatever role that you play within the overall system, I think for those of us who have an interest in disaster medicine, know something about disaster medicine, et cetera, we should seek out those that should be involved and have some knowledge, as Saleh says, because they're not going to seek you out. I recall when I was Director of Emergency Management for my medical center, one of the things I did was, over the course of maybe about a year, I made a point of going to each department that might be relevant to any kind of disaster response and try to spell out to them in a sort of presentation format what exactly their role will be if and when a large mass casualty should happen. And many times they're very receptive to that, but again, they won't necessarily seek you out. I think you need to seek them out. It's part of our kind of trying to educate the world about disaster medicine.
I warn you, Paul gonna ask a tough question. I'm not.
Yeah.
Saleh, thank you. Paul Gersh from the U.S. I was really glad that you spoke about the role and importance of social scientists, since that's not been raised in the last 2 days. A lot of what we discover in disasters is systems fail to achieve the results that we planned for. There are a lot of signals, but many clinicians fail to have the proper lenses. Social scientists are experts in translating that. Say a little bit more how you plan to work with sociologists, psychologists, anthropologists to help implement some of these change management behavior modifications in the Emirates.
So what we are trying actually, Paul, is to embed them throughout. So COVID proven that we cannot work unless we're mentally ready. So psychosocial aspect is a crucial cornerstone now of all what we do. We're working, and one as a quick win is the project is preparing a psychosocial disaster response team. That's the first one, so at least a quick win. And the second thing, one of the sort of courses will be hopefully a mandatory, you know, not to mandate it, more of push it to the providers that with licensing, I think we will need some mental health training as well, and of course with maturity we will grow on that. So I'm a firm believer of the importance of this. We all worked under pressure, and we see the value of any training that we do. I'm lucky to have my wife as a psychologist, so I'm very passionate about what I do, and I do see the value of what they do.
Just as a follow-up, you talked about engineering, so how are you incorporating human factors and risk hazard analysis frameworks into your national plan?
Two things. One is I think we need to know the system. So getting the governance aspect allows us now to go deeper and open books and black boxes that people try not to open. The second thing is data. With engineering, you need to, healthcare, as you know, is a very complex system. You open one faucet here, something happens on the other side. So it's not an easy thing to do and adjust. But I'm, again, a believer of data and integration, because once you do this change here, you will see the effect through data and through outcomes. So having this integrated model, I think, is a good way, but we need smart people like you.
If I could just go back to the Canadian question a little bit earlier, just some of the things you're trying to achieve with these projects, as Saleh laid it out, it wasn't a day, month, year. This is longer term vision over a consistent period of time. And where you're in the system and you're the person who's invested in this idea, invested in the change, not everybody is going to believe you in the beginning. So there's a couple of things that can help you along here. You've got to seed these ideas out for quite a period of time so that some of the ideas are coming from other people. Ultimately, what you're trying to do, part of this is the art of negotiation and getting to yes. And there are two very good books to read on this concept. You're trying to convince the other party here that the idea you have is something that they've originated themselves and that they have the solution, which is actually the plan that you want to get implemented. You're trying to convince them in a roundabout way that when they come to you to ask you to do this, that they're saying this is what they wanted originally, it's their idea, and you're just the implementer of the idea. So achieving that cultural change can take quite a little bit of time to get the seeds into the right places, to get the ideas formed and changed, getting your small wins and consolidating and building. And as Saleh said, he had to look back to himself in doing this, that I was explaining this wrong to people. I was just too into the weeds, too into the small parts of the problem, rather than giving the big pictures and the bits that are relevant for each person. And taking the small wins, consolidating, bigger, 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 and you get the prize at the end, which is that change in the system you're looking for. But it is time consuming, it's labor intensive. But if you truly believe it, that it's the way to go, you need to lay yourself a plan and framework and a couple of other people invested with you to get it done.
Terry?
Absolutely.
So I just want to applaud you, Saleh, for this project over the last 20 years now that's taken this kind of a handshake that you've had with your institutions and with other institutions to get to where you are now. This is kind of the biggest, most amazing success story in emergency medicine development on a national scale that I think we've been able to see. As we know, though, there are another 100 countries or so where this type of thing needs to be done. What do you see, this was said by, I think, each of you individually, what do you see the role of academics, partnerships with organizations like the Health Authority and those equivalents in other countries? What do you see the role of that playing over the next 10 years as medicine changes so much? And this can go to all of you.
I think it's more of how both parties agree to it. It's like a marriage, right? So I think we need to buy into each other. Some academias are there just to ask for money, give us a grant, and the government is not that what they want. You need to be able to solve their problems. So it's a two-way approach. One, you need to speak the government language, because honestly, having people like myself and others who look at it from a government side, but have a close relationship of academicians and the different entities, will be able to express what are the burning issues now in the government. And again, it's different between one country to another. The second thing is how the academia comes and proposes innovation as well, because the consulting firm hires you and me and go and present those on their behalf from a commercial side. You need, I think, as a government, we need to hear it from a non-for-profit approach, that they're there to solve the problem rather than milk you. And it's of course, everything costs or has a cost. But I think it's just more of history of government versus consultancy wasn't as good. So I'm promoter of academic collaboration. Research is huge. As I mentioned, utilizing the data, academicians are safe. Consultancy may, have a different opinions, but usually, especially with local universities, that's someone you know. That's a data you know. If you give them those data or data lakes, actually it's hosted by universities, many of those. So this is, gold mine. We can do huge changes in disaster medicine and in the field if we utilize it properly. So I do see it growing, but there should be more trust in between.
Let me maybe follow up on that. I mean, let's be perfectly honest. Saleh and I, and we've been talking about this for years, and there's a friendship here and a trust, right? So that obviously facilitated this kind of relationship. But the reality is, I think, as Saleh illustrated through his entire talk and just now, and you did, there is a great benefit by having a relationship like this. So it's like, how do you do this without that kind of, prior relationship and trust? And I think it's a matter of convincing. Honestly, maybe this is a stretch, but it's almost like the relationship between WADEM and WHO, which is improving now. We have a great relationship with WHO in a number of different areas. I don't know if Flavio's here. I don't see him, but we've taken a number of different steps in that relationship. WADEM is a safe place for WHO, right? So WHO has all these things they have to deal with, donors and this and that, and different hoops they have to jump through. WADEM is a much safer place because WADEM brings sort of the scientific, academic, research, non-threatening piece to, disaster preparedness response, let's say in this case. Academia and government entities like the Department of Health, it's the same relationship. So while you may not have the same kind of relationship that Saleh and I did for 15 years or more, whatever it might be, it's a matter, I think, approaching government entities equivalent to CPAR, like our ASPR and that sort of thing, and say, hey, we're a safe haven for you. Let's build that relationship. Let's build that trust, essentially, and take this, baby steps, like you say, small little gains and build it into something bigger.
And maybe one last message is building this relationship not at an individual level, as a system level. Because I always say, if I leave tomorrow from the government, at least the hospital preparedness program is gone. There's a course coming, another batch is coming. The governance is moving. The EOC is already in a tender. That's going to go out. So there are things that could, there's a succession plan for what happens. So building it, yes, it starts with individual relationship, but the way you execute it, it has to be system and embed this relationship rather than just one person doing it for personal gain or, for other things. You need to show that this is really a system development and a mutual relationship. So having it a broader rather than a very centralized approach.
Please.
Dr. Faris, Mohammed Naeem, I'm a colonel in the United States Army. You talked about civil and military integration and cooperation. How would you align your lines of effort and lines of operation between the civil and military command and control systems in the initial phases of a disaster? Because in the US, according to the US law, posse comitatus, military cannot actively intervene in civilian affairs until it is allowed to do so through defense support of civil authorities, which means that in case of MASCAL, I may be very useful in a local hospital a mile away, but I must report to my command 10 miles away, and after accountability, wait for instructions. Thank you.
Thank you so much. I think we both share the background. So two things. One is the military in general. In case of operations or war, there's an expectation that the military will take over the management of the healthcare system. That's right. That's the way we think. I come from a military background. The second thing is you need to tell them, now I'm in a civilian world. I tell them, which is true, I'm preparing the civilian system to serve the military in case, God forbid, anything happens. So they love this. They like it because honestly, it is somebody helping them to stabilize And in case of operations, those are beds and cares and systems, trauma system, disaster management system will serve them during the war operations, we call it. The second thing is having a room for them. So in that EOC, it's actually a concept that we're creating from a pre-hospital provider, hospital providers, and a government with the different projects that we have. But then we are creating actually a space for the military, what we call the strategic partners. So we are oil rich, so we have a big oil called ADNOC. We have a big oil industry company there. God forbid any emergency happens, they need to be able to work with us in the civilian system. The second thing is the military. So we're creating a spot within that EOC, and also they are with us in the table when we put the policies and standards. So they don't feel disengaged. They're actually within us. I'm meeting with them frequently. I'm meeting with them next week. It's actually a cohesive relationship that whatever we do is for them as well to serve. So it's just working together, bridging. It's not a civilian military, but actually a cohesive relationship.
Thank you very much for this great presentation. I'm Dr. Michel Yao, the Director for Strategic Health Operation in WHO in Geneva. My question is related to a more comprehensive approach. We are pushing countries to have a kind of integrated approach within the health system. So how this emergency management approach is embedded into the health system, and how do you interact, for example, with the public health entity dealing with disease surveillance or surveillance of new pathogens that can trigger, for example, an emergency that you will have to deal with? Thank you very much.
Thank you. So the integrated model is important. Actually, we're working with them very closely. If you remember the org chart of the Department of Health, we have workforce, we have facilities, we have different sectors on, and they know we speak that language, but from an emergency end. For example, there was a big emphasis of center of excellence, stroke center of excellence, and oncology center of excellence. And I said, you know what, actually in an executive meeting, I said, guys, you think at the hospital, but where does the patient go in the pathway? In the prevention, what are we doing? So we went back to the public health center. What happens in the pre-hospital? That's for us. So the patient should be patient-centric. And I tell them, it's like the train, the center of excellence is just one stop. So we are very well integrated into that. We're working with the system finance, as I mentioned, and so on. So we're very well embedded, but we're trying to show our identity as a specialty. We cannot just be thrown at the side and just be dealt as access to the hospital. No, we're actually a sector by ourselves, a specialty by ourselves. You guys one day gonna need us, and similar to the stories that we always, highlight, they need us. Similar to the scenario that they played yesterday. What happens to those victims? Where do they go? The politicians gonna be here. They're gonna come and look at this auditorium. What happened? But just for news? No. We need to prepare the system, and that's where we advocate. The second thing, I think, from a public health, there's, of course, after COVID. We've agreed with them that the, syndromic surveillance, the outbreaks management will be done by them as a, subject matter expert, but we coordinate it as a CPAR, or Center of Emergency Preparedness. So they become our subject matter expert when it comes to communicable diseases. They do the surveillance, they follow the data, they decide on vaccines, but we stockpile, we purchase, we coordinate, and then we work. So it's more of how you work. As I mentioned, you cannot work alone. You need to understand that there's always this mutual benefit, and they tap into us now for data and for information and expertise.
Great. Well, thank you. Thank you, Saleh, and thank you everyone for joining for this lively discussion.
Thank you.